It's a really pleasure to share with you tonight this webinar. Yes, importance of post-operative protocol in lumbar disc replacement. It's a huge question, and you know that intervertebral discs provide constrained mobility to the spine and serve as the primary stabilizers of the functional spinal night. The generation of the intervertebral disc increased after 40 years of age and is a common cause of chronic low back pain. Functional spinal unit cannot tolerate body loss at rest and movement becomes a source of pain. Until recently, fusion surgery was the criterion standard. This replacement surgery aims to conserve physiologic movement at the segment involved in the motion, and rehabilitation procedures have been recognized as a necessary factor for a favorable outcome. Lumbar pain due to degenerative disc disease with time destroy the entire kinematic chain. Reason why post-physiotherapy is important. Specific training of trunk and limb musculature is crucial to gain maximum spinal and postural stability, balance, and energy transfer throughout the body. But there is no consensus between surgeons due to the surgeon's varying opinion. Important aspect of the post-operative protocols emphasizes sufficient healing time and a gradual return to normal activity to allow for good device to bone incorporation. The post-op protocol, there are 4 key aspects. The first one is early ambulation. The second one is use of a corset or brace. The third is the steps to return to normal activity, and the fourth is return to work. Early ambulation. This is general agreement in the literature that patients undergoing disc replacement will benefit from standing and walking as soon as possible following surgery. In my practice, patients stand up the day of the surgery. Use of corset or brace. There are some varying opinions on the use of bracing. Some surgeons believe bracing is not necessary, while others may prescribe bracing as needed for patient comfort. I don't know if you remember the time of the charity. A study was done in the 1980s years about brace and motion after disc replacement. And with the charity, patient with brace has lower range of motion than patient without brace. For the ESP, lumbar, in my practice, a custom-made brace is used for 4 weeks to avoid torsion and twisting movement. The soft belt could be wear for more 3 weeks. And I didn't observe a loss of range of motion with brace with the ESP during my experience. Third, the steps to return to normal activity. There are 4 phases. The phase 1 is active rest phase. Patients were mobilized with the help of the physiotherapist on the first post-op day. Patients should keep mobile, change the position frequently, and should not sit in the same position for more than half an hour. Maintaining the correct posture was explained to the patient on post-op day. Patients were instructed to avoid lumbar hyperextension and keep the back straight. Do's and don'ts after lumbar disc replacement surgery. Not rotation of the lumbar region for the first 3 weeks. No curving of the lumbar region for the first 6 weeks. No intense abdominal exercise for 6 weeks. No participation in competitive sports for the first 6 months. Avoid lifting, twisting, and hyperextending for the first 6 weeks. Try to keep back straight. Can swing after 6 weeks. Can jog after 6 weeks. And can drive after 2 weeks. The phase 2 is early protective phase. It's during 4 to 6 weeks. This is the pelvic tilt exercises started in pain-free limits, and the patient should walk as he wants. The phase 3 is a dynamic phase. It's during 7 weeks to 6 months. This is a core strengthening exercise according to patient tolerance. Dynamic lumbar stabilization exercise is started in pain-free limits. Any exercise that causes an increase in pain must be stopped and excluded. Kinetic chain exercise program, including proprioceptive exercise, was individualized according to the patient. The phase 4 is back to the sport and walk after 3 to 4 months. Patients were allowed to participate in sport activities. Activities involving low resistance, height repetition were preferred. Contact sports were allowed, but the risk of falling and impact were explained to the patient. Patient's preference was an important determinant of choosing sport activity. Special precautions are taken according to the preferred sport activity, and training program is individualized. To have a dog is also very helpful for this kind of exercise. Special recommendation for return to work. This depending on the type of work. For those who have office works, 1.5 to 2 months is the rule. For EV workers, 3 to 4 months is the rule to return to work. What I am doing. In pre-op, I'm asking the patient to perform muscle strengthening and stretching to be prepared to surgery. I think it's very important to ask the patient in pre-op to do some exercise to arrive for the surgery in a good shape. At the end of surgery, when the patient is still on the operating table, I flex the hips 5 or 6 times for fixing the prosthesis anchorage. During the first 6 weeks, patient wear a brace. They have to avoid extension, torsion, and twisting. Flexion is permitted without restriction. Flexion stabilizes the prosthesis. Sitting position is permitted just after the surgery. Sitting position is stabilize the prosthesis also. Walking is allowed without no limit. Sexual activity needs precaution to avoid great movement. After 6 weeks, return to work average 4 to 6 weeks, but could be up to 12 weeks depending on the physical demands of the job. Physical therapy should start right after surgery and continue through about 6 weeks. A gradual progression of Nordic walking exercise and limited weight exercise, max 10 kg, were typically prescribed starting around the 3rd day post-op. Full sports activities were not recommended until after 12 weeks. In conclusion, management of the postoperative patient following TDR varies somewhat among surgeons. It is up to each surgeon performing TDR to base their own postoperative care on their own knowledge and experience of the device, surgical procedure, and patient characteristics. However, one goal remains constant: sufficient healing time and limited activity to allow for good device-to-bone incorporation. A good result is a combination of good indication, trained surgeon on the device and technique, aware of specificities of the device, ready to follow the device guidelines, and ready to follow the recommendation of the spine innovation. And you have on this slide the link where you can find the recommendation of spine innovation for this prosthesis. Thank you for your attention.